There we go. So thanks for joining us. I know this is last minute, and depending on how this goes, we may do this every week. Who knows? If you want to come on, that's good. Question is this a recruitment webinar? No, it's not. This is treatment planning, because treatment planning it's so important. Those of you who are younger learn how to treatment plan perio. Those of you my age, you learn to treatment plan the entire case. And while today we're talking about aggressive periodontitis, and I'll tell you about that in a minute, and then we'll go through the session. The fact is that we talk about being the director of dentistry, and so my purpose in these training sessions, these treatment planning sessions, are going to be to assist you to become a director of dentistry. What does director of dentistry mean? Does it mean you're doing all the dentistry? No, but it does mean you're thinking through the entire case. It means you're thinking from a restorative standpoint as well as from a perio standpoint. And while today we're talking about only perio, that's all we're talking about, the opportunities are there for you to become a much greater asset to your patients and to your referrers, or to the people you're referring to. And to the degree that you can raise the bar in terms of your thinking skills, that's our purpose here. So today is not going to be an implant day, but other days will be implant days. I'm working right now with one company to give continuing education credit. And while I can't offer continuing education credit for this one, hopefully by the next time we do this, CEUs will be established, or at least you can get a CEU or two or whatever, however long this takes, probably one for each of these sessions, so that your time is not only well spent, but you're also getting compensated in terms of CEUs for your time. So I'll tell you a little story first, and where this is coming from is that I had a patient come in on his own. He had seen the general dentist. The general dentist had done scaling and root planing, and then there happened to be a periodontist. I guess a visiting periodontist, maybe part-time periodontist in the office. I don't know. I haven't met the person yet. Periodontist, and the case didn't resolve. And so the periodontist said, well, obviously there's nothing can be done. You need to have all your teeth taken out and have dentures or implants or whatever it was. And so the person was very concerned, so she came over here, and we can save every tooth. Might be one that we can't save, and maybe later on a second one that we can't save. But the rest of them we can. The difficulty that many people have, and I don't want it to be periodontists who have that, is that we have the feeling that we can't treat perio when we can. The most difficult case to treat is not the perio case, particularly a case that doesn't have very much mobility. You know what the most difficult case to treat is? It's the caries case. You have rampant caries. I can very seldom get rampant caries under control. You have advanced periodontitis. It's a matter of getting through the advanced periodontitis or aggressive periodontitis and getting the patient healed. And I can tell you, 95+% of them are going to heal. So here's a periodontist who is looking at a case and saying, nothing can be done, extract the teeth. And here's another periodontist saying, of course something can be done. We can save nearly every one of those teeth. That's the difference. We can't have that difference. Most of the people who are watching this session, either live or watching it on video, are periodontists. So we're going to talk about that, because if it's happening right here in Melbourne, Florida, it's happening in places, well, it's happening to you. And maybe you never had the confidence of treating aggressive perio. So I hope to be able to share some data with you and some treatment that we do, and give you some ideas as to what you can do in order to be able to help your patients. So let's go and let's get onto the treatment planning session today, which of course, as you know, is aggressive periodontitis. These are the people who are active that help in the idea. So You haven't met Danielle, haven't met Jennifer. In some way you would meet them, but this is not an ideas session. It's brought to you by the Ideas, but it's absolutely free. You don't have to pay any membership for this, nor will you for any treatment planning session like this. So we've got a 49-year-old female. Okay, and I'll read it because some people are listening to this in the car or whatever. The patient wants to be sedated for any work, so she's scared to death. She had a bad accident when she was younger and had trauma to her front teeth. She said the office back then said all her teeth were going to fall out in 20 to 30 years, and she said that started happening. And now she's missing all of her front teeth. She's interested in implants. She's currently unemployed due to COVID, but said that her mother is going to be paying cash for all treatment. And she's scheduled on Wednesday, June 17th at 8:50 a.m. Okay. So at this point, and I showed this before we started recording, I will get a letter like this, or I'll get this along with the patient's phone number, and I'll call that patient that night, the next night, to talk to the patient, to give that patient reassurance that she's come to the right place, and she can talk to the doctor even before she shows up in the office. That doctor phone call makes a tremendous difference. So I'll get this along with the patient's name and phone number, and I'll give her a call during my free time during the day or at night, after work, whatever it is. I'll call the patient and either talk to the patient or leave a voicemail, a quick voicemail saying, "Hi, it's Dr. Sheldon. I'm glad you've called us. We're going to help you, and look forward to meeting you on Wednesday, June 17th at 8:50 a.m. And that's all it takes. Sometimes the patients want to share a little bit of information. That's fine. You can start to build a relationship before the patients ever come into the office. And so that way when the patient comes into the office, some of the chit chat is over. You've already had the introduction. Now you're in the middle. Now you're talking with the patient. So important. Okay, so I make the doctor call, and we talk to her more, and she says she gets migraines, and they're at the base of the skull behind the right eye. She's on Imitrex as necessary, amitriptyline, Zoloft continually. Okay, so I'm getting a whole heck of a lot of information that she never shared at her initial phone call. We don't want to get all this information in the initial phone call. Initial phone call, we want the patient to make an appointment with us. That's all we want. Okay, now we get all this information. She said cervical therapy, cold laser. I want to know if migraines could be due to the teeth. I doubt it. She was quoted $48,000 to graft some areas around her teeth. She wants partial denture. She talked about nutritional therapy, which she's not tried, and I'm very much into nutrition and natural healing, even though we do some of the most complicated surgery that you would see a periodontist doing. And she's mostly pasta with vegetables, so at least I've got that out. Okay, so now she sees us, and she's seeing the assistant first. She's walking to the office, and she wants her periodontal condition taken care of, and she wants to partially replace the lower teeth. Okay, so let's take a look at the X-rays. So let's take a look along the FMX. You can see how much bone loss there is, okay? Bone loss, bone loss, bone loss. Bone loss of the apex, okay? Can I save that tooth? Absolutely not, I can't. Bone loss, bone loss. By the way, this one is no longer in function. Do we even need to keep member 18? Well, maybe to support a partial denture, but in this position, it's way too high. So the answer is no. Number 19, you've got what looks like a class 3 FERCA, right? Can you save that? Yeah, if it's not mobile, you can save that. Save that for a long time. Just look at that tooth as two different roots, okay? Two bicuspids happen to be connected in the middle. And if there's bone support on the distal root, and bone support in the mesial root, and she's functioning, although she won't be functioning against this tooth because this tooth is coming out, yeah, why not save that tooth? There's no reason not to. Okay, come across, we take a look. Bone loss, bone loss, bone loss, bone loss, bone loss. There's a bigger classification with an angular defect here. And so, yeah, person certainly has periodontal problems. Let's take a look at the CT scan. And by the way, I take a CT scan on everyone. Yeah, everyone. I have the CT scan. Why shouldn't I take a CT scan on everyone? It gives me so much more data, okay? And for the minimum amount of radiation in an advanced case, I can get an awful lot of data, which I can use later on. And we do implant treatment planning on others, we're not doing an implant treatment plan on this one, you'll be able to see how much data you can get with a CT scan. And the better part of it is, if you don't charge for the CT scan, you'll get the CT scan every time. And then you can use the CT scan for treatment planning. But if you say, hey, it's going to cost $250 for the CT scan, you've lost the opportunity to take that CT scan for the patient. So check my website, drleesheldon.com, $79, includes CT scan, full-on series, complete examination. And I couldn't practice without it. So let's take a look through the CT scan. Let me see if I've clicked this correctly. So now we're scrolling through. Buccal is on the left. You'll see the enlarged view right here. Okay, there's no bone support on tooth number 4, so we're not going to be able to save that. But look at mesial and distal, you've got buccal and lingual, I'm sorry, you've got bone support. Okay, it's not a lot, but you've got bone support. She's happy. The teeth aren't very loose. You got bone support. There, you don't have bone support, do you? So 14 or 15 or whatever that is, no bone support. We're not going to use that. Okay, now I forgot the exact treatment plan, but we'll go through this. Okay, so 18, it's not very good. Number 19, there's some bone support on both those roots. 20, bone support. 21, there's bone support. Maybe a little bit of caries in mesial number 21. 27 bone support, 28 bone support, 29 bone support, 30, there's even some bone support. Okay. And when we talk about implant treatment planning at a subsequent visit, we can talk about measuring the mesial distal width, showing the patient how you can place implants and where the implants are going to go, even using some treatment planning software, which is helpful to you and really helpful to the patient to visualize what the problem is. Let's take a look at her. Okay, so you can see, what is this, a punched out papilla? Maybe, I don't know, it wasn't painful, but you certainly have a lot of plaque there, and you've got different periodontal problems. Certainly aesthetically, we don't have the greatest situation in the world. And if the patient approached me and said, I want aesthetics, that's my primary concern, then I might think about it a little bit differently. But that's not her concern. She just wants to save all the teeth she can so she can wear a partial dent from the lower. That's all she wants. You know, we're probably the biggest implant practice in our county. But it doesn't mean everybody walking in gets dental implants. We're not one of those implant centers. We do everything the implant center does. But you're periodontist first. That's the biggest advantage that we have. We're periodontists. We know how to save teeth. So let's take a look at some of these pictures and see a little bit. Plaque control is certainly a problem. Nothing that you would look at that you'd say is, or that would look out of the ordinary other than severe periodontitis. Take a look at these pockets. Okay. Take a look at these mobilities. Class 2 mobility, class 2 mobility, class 2 mobility. Okay. Class 4 mobility. You know, I know there's no such thing as a class 4. Class 3 that I absolutely can't save. And I know I can't save as a class 4. So you're looking at the mobilities here. Now, most people will look at this, and that means general dentists and oral surgeons, and unfortunately some periodontists, and will look at this and say, well, you got a class 2 mobility, it's just a matter of time before it's going to become a class 3 mobility, and you're not going to be doing anything, you might as well be able to do anything, you might as well get the teeth out now. Right? Wrong. Absolutely wrong, 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 wrong. If you as a periodontist are not going to be dedicated to saving teeth, tell me, who is? Who's going to look at the patient and is going to say, listen, I can help you? Because that's why the patient is going to the periodontist. In fact, sometimes that's why the patient is referred to the periodontist. And while I don't necessarily believe that the referral relationship is where we are going in the future, it's still a relationship that you have right now. Of course, you know, our whole thing is get the patient coming into us first. And that's what we teach. We want people coming into first, so you're the primary care person. You're the one who determines which teeth can be saved. You're the one who determines how it's going to be restored. And then work with the best restorative dentist to do so. But Different people tuning into this right now are in varying stages of that relationship. But we also know that many of us are in a situation where we're saying, hey, we're not getting as many patients. What can we do? And what we can do is be periodontists. We can save teeth. So this is a case where we can save teeth. It is. As long as you saw that buccal lingual bone support, you can save these teeth. Okay, so Melanie has aggressive periodontitis. There are 2 teeth that cannot be kept. Those are number 14. Oh, and there was a root tip number 16, sorry. We're going to extract number 14. We're going to do laser disinfection of the pocket, which is very, very close to the sinus. By the way, we're not doing laser disinfection of pockets anymore, of extraction sites anymore. We found out the patients were doing worse with laser disinfection than when we just did PRF or did nothing at all. So the laser disinfection idea in our hands is gone now. Okay. Small root tip number 16. We're going to take out number 18 at the same time as we take out number 14 and 16. So 18 was the one that you know was super erupted, and that's coming out. She has highly aggressive bacteria. I want to do the following. Now, how did I know she had highly aggressive bacteria? Except microscopes. I took a little sample below the gum line, and I put it on a slide, and I put it on the microscope. We put it on we projected it, and you get a whole microscope set up then for what, $3,000 or $4,000, and let the patient see the bacteria show. I know there's some out there who say they can do full diagnosis with a microscope. I don't believe them, but for educational purposes, microscope's great. So, but where we can make a diagnosis was with the oral DNA test. And there are other tests, similar tests out there. I've been using oral DNA for 10 years. I love the company. And so we use the oral DNA test. You'll see how the oral DNA test can be so valuable in terms of diagnosis and in terms of differentiating you from everybody else, because oral DNA test is something that's not done. So now we've got a doctor phone call that's not done, an oral DNA test that's not done. You're separating yourself just by being a little bit different and being a little bit more thorough than others might be. Okay, so let's do oral hygiene, electric toothbrush and floss. Let's do perioscopy. I use perioscopy as my primary modality of treatment. I think we're all agreed that debridement in whatever way, and whether you're going to do it with a laser or perioscopy or a combination of both, or with osteoperiodontal surgery, if that's what you feel needs to be done, the whole idea is to breathe the root. I just think you can do a better job of it with a periscope. And besides that, if we do it with the periscope, the hygienist can do it, and I don't have to do it. See, I, as the doctor, can then do more complicated procedures, and the hygienist can do it at half the cost. So, I mean, whether you choose to do laser therapy yourself, or which is going to be a more costly thing, or perioscopy, which is less costly because the hygienist is doing most of it, that's up to you. The idea is cleanliness, because once we have cleanliness, then the body wants to heal. Okay, like we're going to be prescribing an antibiotic after the oral DNA test is given. I'm not certain about number 4. Number 4, based on the radiograph, probably is going to be lost, but let's see how much healing we can achieve through initial preparation. Once we've completed the work, then we'll decide on the stability of the teeth, and then likely fabricate a lower partial denture, replace numbers 22 through 26. Now, sometimes I might give her temporary partial denture right away, or have the general dentist do it, but she's been without these teeth for a long time. You know, why do I have to put something on these teeth right now? Let's take our 6 weeks or whatever to get the periodontal condition stabilized, and then make the partial denture. If she's losing her teeth right away, yeah, I'm going to replace it with an Essex or with partial denture or with something, just so the patient isn't handicapped socially. But there's the oral DNA test. So you take a look at on the left side, high-risk pathogens. Okay, so essentially what we're doing is having the patient rinse out with a saline rinse, spitting in a cup and sending out to the oral DNA, sending out that saliva sample to the oral DNA lab, which is Minnesota. And within 10 days, we get this kind of report back. Okay, so the red complex are the worst, the yellow complex are next. If they're above the line, then they're above threshold, and threshold is often important. By the way, not always important. Sometimes we see people below threshold, and we'll still treat them with antibiotics. Okay, but we got 3 high risk, 4 moderate risk that are above the threshold. The bacterial species, which is Treponema denticolum and Porphyromonas gingivalis, are strongly associated with chronic periodontitis. They're transmissible and tissue invasive, even at low amounts of these organisms. Okay, so we've got an entire description, which not only you have to educate the patient, but the patient brings this home. And not only can you see, not only can the patient see that these bacteria are related to periodontitis, which is what the patient's here for, but take a look at the third dot right down here. The detected pathogens are also risk factors for various systemic diseases, including atherosclerosis, type 2 diabetes, arthritis, dementia, and several types of cancer. Recently, Porphyromonas gingivalis has been isolated from the abnormal proteins seen in Alzheimer's disease, and is thought to be one of the causes of dementia. How powerful is that? How powerful is that when the patient sees that? And now I'm going to ask you a question. No, I'm not going to ask you the question. Let's go to the next slide first. Okay. So again, here we are. And here are the recommendations with regard to treatment. For those of you who think amoxicillin and metronidazole works for everything, it doesn't. And in fact, from the oral DNA test, we get suggested treatment protocols. Treatment protocol number 1, clindamycin, number 2, Cipro, and number 3, clarithromycin. Okay, number 1, if the patient's not allergic, clindamycin. Now, I got to tell you, most of our patients are not clindamycin patients. But I also know if I prescribed amoxicillin and metronidazole, that this patient wouldn't have had a result based on this finding, or they may not have had a result. So if I see that a laboratory is going to tell me that the first choice is clindamycin, what am I going to do? In a patient who has aggressive periodontitis, am I going to say, well, I'm not going to prescribe an antibiotic and we're going to see how we do? No. You know, that's silly old-time thinking that, well, I don't need it. This person has an infection, and look at it from an infectious standpoint. If you had an infection in any other part of your body, what would you do? Okay, so let's not look at this idea that scaling and root planing is the be-all and end-all. If it doesn't work, then there's a problem. We look at these patients prospectively. And if the patient has aggressive bacteria like this, you're darn right I'm going to prescribe an antibiotic in conjunction with therapy. Now, by the way, in perioscopy, we don't prescribe it too early. We prescribe it, have the patient start the antibiotic the day before treatment. Why? Because if they start the antibiotic a week before treatment, the pocket closes up so well that it's difficult for our hygienists to get the pocket back so they can see where the peries go. So timing is important on this too. So oral DNA tests, nobody's had this done. And if you talk to the oral DNA company, well, they're very popular. If you take a look, there are probably not very many people in your location who are using oral DNA and using oral DNA on a regular basis. And while we can't, and this test costs, I think, somewhere around $99, and the patient pays for that. You know, I say, you've got periodontitis, I want you to spit in a cup. That's not included in the original $79. I want you to spit in a cup, and here's the treatment. It's going to be this, it's going to cost this amount. But before we do it, I want to find out what bacteria is growing there, so I can prescribe the right antibiotics because that bacteria has already invaded your tissues. I can't do anything about the bacteria that's invaded your tissues. I can clean the dirty root, but the bacteria has invaded your tissues. That's something that we need to kill with an antibiotic. So the patient gets it. The patient understands it. So 10 days later, after we've done this sample and we look at this, we call the patient and we say, hey, listen, you've got some bugs. I'm going to send you a copy of this. By the way, these bacteria are associated not only with periodontitis, but some overall diseases. I think it's important that you look at this report. And I can email the report out to the patient, or I can give the report to the patient at the next visit, however you choose to do it. But I guarantee you, if you called the patient and said, I'm going to call an antibiotic in right now, I want you to start taking it on Monday. By the way, I'm going to send you the report, and you email this report to them, You think they're going to look at this report right away? Particularly when you say it's not only associated with tooth loss, it's also associated with disease. And let them take a look at Alzheimer's. Let them look at diabetes, heart disease, cancer. Let them see the association. And this spells it out just beautifully. Okay, so this patient, we're bringing in the anesthesiologist. So we're doing sedation with Dr. Perez, and then we're going to extract 14, 16, 18. Curette the socket, remove infection. And this is exactly what happened. This is the summary note. We sutured the area with chromic RSC, who's Rebecca, our hygienist, has been doing perioscopy for 20 years. Came in to do the root planing procedure, which is really the perioscopy procedure. So this was all done under sedation in one single operatory, where the periodontist saw it first, my associate, Dr. Furtado. And then Rebecca came in and she did her thing, and Rebecca saved an awful lot of teeth. So she's going to be in there with the periscope for 3 hours plus, getting those surfaces clean. And she'll do it. And the patients will do better. The patient will do better. This much better. Okay. So this is 6 weeks later, and take a look at the pockets now. Now, the question you might say is, well, does that hold up? And the answer is yes. The question you might ask is, what happens if you don't get that result? I'll say, I almost always get this result with every patient, and the chance of breakdown occurring, while higher than the non-periodontally diseased patient, is not that great at all. I mean, if they have lousy oral hygiene, if we haven't done our job or they haven't done their job, yeah, there's going to be some breakdown. Sometimes, as a result of killing one set of bacteria, a new set of bacteria shows up, and I have to run another oral DNA test. In fact, it's a good idea to run. This is called my periopath from oral DNA. It's a good idea to run a second oral DNA test after you've done the first one to make sure you've got the pathogens under control. But if you don't get resolution, often you've killed one bacteria and another bacteria shows up, which may now respond to metronidazole, and then you then you prescribe that for those few cases that aren't going to resolve. Sometimes the cases are viral in nature. Many of you have heard of Dr. Jorgen Slotz, who was a periodontist and a microbiologist at the University of Southern California for years and years and years. And for the past 20 years, he's told us that viruses, cytomegalovirus, herpes simplex, are involved with this disease as well. And occasionally, very, very occasionally, we'll prescribe something like Valtrex in a patient who hasn't responded. But you see, in aggressive disease, there's bacteria there, maybe viruses. If you take care of them and you take care of the etiologic factors, these patients heal. The teeth get tighter and they stay tighter. And we'll see these patients every 3 months. We'll continue to see them and continue to make sure that they're doing okay. And yeah, if something recurs, we might run another oral DNA test. We just nurture these patients, keep these patients going. And the vast, vast, vast majority, as I'm saying again and again and again, these patients will do well. So I think is there anything more in this? No, that's it. So let's do a stop share for a second, and I'll take your questions. There's a Q&A box on the bottom. I see one question right now. So how do they determine antibiotic susceptibility? They actually played out bacterial isolates and used discs for sensitivity testing. No, this is not a culture and sensitivity test. So how do they do it? I don't know. And frankly, I've been doing it with them for many, many years, and they've been foolproof. So do I have to know how they do it? No. All I can tell you is that the results have been uncanny. Now, I did culture and sensitivity for a number of years. I did. And depending upon where I sent the sample, I would get different results. And culture and sensitivity didn't work very well. I mean, there were times when I was sent it to University of Florida. And sometimes we'd get there in a day when they were doing this kind of thing. but often it was University of Pennsylvania or sending out to California. And whether it survived or not, or the culture technique, I don't know. I just know that the oral DNA test provides me with these results, clinical results. I'm a clinician. I don't go into the research. If you want to contact Oral DNA Lab and find out how it's done, please do so. It's important. Find out. But the fact is that the antibiotic protocol works. And it works so often. And better than any other DNA probes that I did and culturing, because I've been doing culturing and all these sampling techniques for my entire career, that I can just tell you, we're not even culturing. We're not even taking a sample with a paper point in the pocket. We're having the patient switch with a liquid which is provided by oral DNA, spit in the cup, and send it out to the lab. That's all that's happening. And I'm getting fantastic results. That's what I'm there for, to produce fantastic results. Okay. So what other questions we got? Diane from Oral DNA says real-time PCR is the methodology for oral DNA testing. Thank you, Diane. Appreciate that. There you go. That is the answer to the question. Diane Larson is a hygienist. She works for Oral DNA Labs. She's easily accessible, so contact Oral DNA Labs and you can talk to Diane. Are there any other questions? No. All right, good. So we're going to be talking about other things. Yeah, I'll cover implants. Yes, we'll cover all of the things that we do. I'll try to pick out a case that we've done, or that maybe I've just treatment planned. We're even going to talk about restorative dentistry and how we treatment plan that, so that the patient relies on us for every bit of the diagnosis and treatment planning that we do. I hope you find these valuable. As I said, I'll try to get CE credit for you, not for this one, but I've got some irons in the fire, and I think we're going to be able to get CE credit for this. Any comments you have, just write to me, lee@directorofdentistry.com, and I'll be happy to answer your questions. Thanks for joining us. Hope to see you again next week. Bye-bye.